for the small, underserved, and rural clinicians. Presenting with me today is Sandy Swallow, the QIO Health IT Advisor, who works with groups of 16 or more and larger health system ACOs. Thank you for joining us today to learn more about the quality category for the Quality Payment Program, also known as MACRA or MIPS. We hope you discover some tips to help you succeed in this quality category. Before we dive deeper into the quality category, we will first provide a few basics about the Quality Payment Program. Then I will talk more specifically about the quality category with benchmarks, deciles, and selection of measures, followed by Sandy talking more in depth about the quality scoring methodology. We will also provide links for wonderful resources to help you with understanding the Quality Payment Program. I first want to start off and make sure we're all on the same page. I know that many of you have heard this a lot of times before, but just to make sure that everyone has a general understanding that MACRA is the legislation that introduced the Quality Payment Program, and it did so by combining the three legacy programs into the Quality Payment Program. Those programs were PQRS, or the Physician Quality Reporting System, the Value-Based Modifier, and Medicare EHR Incentive Program, or Meaningful Use. The Quality Payment Program has two paths for eligible clinicians to take. They can either take the Alternative Payment Model path or the Merit-Based Incentive Payment System path. Now this screen shows you that there are eligible clinicians that are defined for 2017 and 18, and in the third year they're looking at adding some different eligible clinician types. So most notably, I want to reiterate for the 2017 and 18 year that physicians are defined as an MD, a DO, a dentist, a podiatrist, optometrist, or chiropractor. In addition, the physician assistant, nurse practitioner, clinical nurse specialist, and certified registered nurse anesthetist. So those are the eligible clinicians for this year and the next. But next year, in 2019, the Secretary may add the types of providers here that you see on the right hand of your screen. We want to talk about exemptions. So you are exempt if you are in one of the three categories listed here. If you have less than $30,000 in Medicare Part B allowed charges, or you see less than or equal to 100 Medicare patients, you are exempt. And CMS is using a 2-year low-volume threshold determination period. So you are considered low volume if either year is low volume. So for 2017 performance period, that determination is made from claims dated from September 1st of 2015 to August 31st of 2016, with a 60-day claims run out, or September 1st of 16 to August 31st of 17. So if either one of those years you are determined to have that low volume threshold, you will be deemed exempt from the MIPS payment program. Now, there are other ways that you can be exempt, and the second way is if you are newly enrolled in Medicare, and finally, if you are significantly participating in an advanced APM. CMS has notified us that the eligibility letters to notify the providers billing under the tax ID numbers are being sent out as we speak by the MACs. And so you will see if your providers are eligible or if they're exempt. So watch your mail for those letters. And those letters are being mailed to the contact information listed in PICOS. And so they've told us that any time from today through the end of next week, you should be receiving your letter. There are a few different reporting options that you or your organization will need to decide which is best for your organization. So first, there is the individual type of reporting option, and this is where you have a single MPI tied to your tax ID number. You would submit individual level data, and you would do that via claims, EHR, your registry, or qualified clinical data registry. And next option is the group option. And this is where a set of clinicians identified by their MPIs are sharing the common tax ID number, and they would submit group level data. Now, if you are a group, of 25 or more clinicians using the CMS web interface to submit your data, you must register as a group by June 30th of this year. We get a lot of questions asking if groups smaller than 25 need to register, or if groups more than 25 need to register if they use a different reporting mechanism, and it's only those 25 or more clinicians using the CMS web interface. And the group can submit the data from either that CMS web interface or EHR or the registry, or also the Qualified Clinical Data Registry. The last group, the last reporting option is the APM entity group, the Alternative Payment Model Entity Group, or MIPS APM. Now, there are many ACOs in Iowa, for sure, I know, but also around the country. And so this is becoming a more important type of reporting option, and it's where there's a collection of entities who participate in an APM, but they don't qualify for an advanced APM or don't meet certain thresholds for payments or patients. And so you would need to make sure that you submit your MIPS data to avoid a downward payment adjustment. And Sandy will talk more in detail about the MIPS APM, but we just want to make sure you understand the differences there. The Quality Payment Program has 4 different performance categories, 3 of which will be used for this 2017 transition year. You will receive points for each category to come up with a final score. And this score is measured against your peers to give you a payment adjustment, either positive or negative in 2019 for this 2017 performance year. There are 3 categories to be used for the 2017 transition year, and those are quality, advancing care information, and improvement activities. The 4th category, cost, will not be calculated into your final score in 2017, but it will be in 2018, so it's important not to disregard that as either in this year. And you will see the weight of each category under the category name, both for MIPS-eligible clinicians as well as for those in an MIPS APM, as I just mentioned. So notice that for MIPS APMs, there's more weight given to the advancing care information and improvement activities category with less for quality. So we'll be focusing on quality today because it has the highest weight for both MIPS and MIPS APMs. So for MIPS providers, it will be 60% of your score, and for MIPS APM providers, it will be 50% of your score. CMS has allowed flexibility for clinicians to decide at which level they want to participate in the Quality Payment Program for this 2017 transition year only. And so if you haven't done much reporting previous to this year in PQRS and or meaningful use, you may want to start small with a test pace. And by submitting just one quality measure, one improvement activity, or 4 or 5 required advancing care information measures, depending on your certification of your electronic health record, you will avoid a penalty. So you will receive either a neutral bonus or maybe even a small bonus, but more than that, you will avoid the negative 4% payment adjustment for those who submit nothing at all. And so we really want to focus on submitting something, and this is an excellent way to do that and to avoid a negative 4% payment adjustment. The next option is a partial year submission of at least 90 days. And if you weren't ready by January 1st, but you do want to submit more than just one measure, one improvement activity, or the 4 or 5 advancing care information measures, this is a nice option. By doing so, you not only will not receive a penalty, but you will either receive a neutral or a small bonus. And you can start your 90 days anytime between January 1st and October 2nd. You must start your 90 days no later than October 2nd, however, to allow for that 90 days for your reporting period. The next option is to participate for a full year in the Quality Payment Program. And this may increase your chances to earn a larger payment adjustment by submitting data on all MIPS categories except costs for this year for the full year. Not only will you avoid that penalty, but you will receive a neutral to moderate bonus. Another option is to participate in the advanced APMs for this year. And then finally, we can't stress enough that the last option is to not participate at all, and that is an automatic negative 4% payment adjustment. So we just don't want that to happen. Now, you will need to report your data by March 31st of 18. So very important for that day. And whether it's just important to note that positive adjustments are based on your performance data and on the performance information submitted, not on the amount of information or the length of time submitted. So that's a different concept, but you may score even better, more points with a 90-day submission if you're very strong in all of your categories versus submitting for a full year where you weren't quite ready until later in the year. So just consider that as you go along your path. But again, I want to remind you that clinicians do not need to tell CMS which option they intend to pursue unless you're in a group of 25 or more and you're going to submit your measures through the CMS web interface. So that really means that you can get down to the final month and decide and really look at the numbers and decide which way you want to go and for how long you want to submit your data. It's just a lot of flexibility built in there. So today, as I mentioned, we're going to focus on the highest weighted category, the quality. And this accounts for 60% of your final score if you are a MIPS eligible clinician, or 50% if you're an eligible clinician participating in the MIPS alternative payment model. It is important to get started now so that you are aware of your quality measure percentages and can work to improve them throughout the rest of the year. There are 271 measures available, and from those, you will need to select 6 measures. The measures don't have to be from any number of domains as you have previously had to do, just 6 measures. And of those 6 measures, at least one must be an outcome measure or intermediate outcome measure. There will be no outcome measure, if there's no outcome measure available to the clinician. If this is the case, you can choose the high priority measure. And that's another option for you there. And we have listed the different domains that those would come from. They could either be appropriate use, patient safety, efficiency, patient experience, or care coordination. Now, if there are fewer than 6 measures that apply, you want to make sure that you submit all that do apply. If you submit more than 6 measures, which is definitely an option for you, then CMS will only score the top 6. They'll score them and then choose the top 6. So just so you know, that is an option as well. There is no cross-cutting measure requirement for this year, as in previous years with QPP-SURS. And you are required to use the same reporting mechanism for all submitted measures. There is one caveat with that. If you choose the CAPS for MIPS option, that is submitted through a CMS-approved vendor. We'll talk about that next, but you can choose that option for the CAPS for MIPS and then choose another option for the other 5 measures. The one surviving administrative claims measure is for groups of 16 or more providers or 200 or more attributed hospitalizations, and that's a 30-day hospital readmissions measure. And that would allow for a total of 70 points versus those in the smaller groups who have a total of 60 points. And we want to stress that the quality requirements for the CMS web interface or the MIPS APM's participation, they are different. So Sandy will talk more about that in a little bit. Now, what happens if you don't have 6 measures? So if you submit fewer than 6 measures, the missing measures are scored, averaged in with those that are submitted. If you have fewer than 20 patients in your denominator, however, those are not averaged in. So you don't need to go beyond the measures in your specialty or subspecialty measure set, and they are not calculated in. So let's say your specialty measures that you only have 4 measures. You can earn up to the 40 points of the total possible 40 points versus if you just are missing 2 measures, you can earn 40 points of a total 60 possible points for those in small practices. So it's just important to remember that those are the specialty or subspecialty measure sets that they give you those options out on the QPP website for CMS. You do not have to choose more than that. And then finally, there will be a reformatted measure applicability validation test, or MAV, coming in 2018. Now, this is a nice little silver lining. There are two opportunities to increase your quality score through bonus points. So, for example, you can score 2 points for submitting an additional outcome or patient experience measure, and you can score an additional 1 point for any other high priority measures. The amount of the bonus points you can earn is capped at 10% of the denominator. So let's say you have a total of 60 points, then the amount of bonus points you can earn under the measure type would be 6 bonus points. There's another option, and that's the electronic submission option, and that's a second opportunity to increase your quality score through bonus points, using the electronic submission with your end-to-end electronic reporting. You'd score 1 point for each measure submitted using the electronic submission, and this is also capped at 10% of your denominator. Now, the qualifications for this include you must have clinical data that is documented in your certified EHR technology. The extraction of the raw data from the EHR must not be abstraction or pre-aggregation. And you will pass your raw data onto your reporting vendor. The vendor has an automated system to process and upload to Medicare. So there's no abstraction or no pre-aggregation. And finally, all mechanisms are eligible for the electronic submission except for claims. Your measure points and your bonus points can never total more than the maximum points allowed in the quality category. And Sandy will discuss this with a wonderful set of examples in the details later. Now, CAPS for MIPS, I mentioned this on the previous slide, but it's the acronym for Consumer Assessment of Healthcare Providers and Systems Survey. And it's a survey to measure patient experience and care within the group practice. Now, this is done using a CMS-approved survey vendor. And this is no longer required. If you choose to submit CAPS for MIPS, it counts as 1 patient experience measure, of which you will receive 2 bonus points, but you will still need to choose 5 other quality measures. And another benefit of using CAPS for MIPS is this also counts as a high-weighted improvement activity. Now, this table explains the data completeness criteria based on the submission mechanism and which payers are included with those patient threshold rates. So, for example, if you are using a qualified registry, you would submit all payer data, not just Medicare Part B, for at least 90 days with at least 50% of patients' data submitted. Now, note that the period and the patient threshold rate continues to increase in 2018 with an even higher threshold percentages in the long term of 90%. So I really like this chart. I think it's a great reference for you to use, and I highly recommend you do use this because it can be kind of a little confusing based on the type of submission method, how much the patient threshold rate and the payers that are involved. Now, as I briefly mentioned, the 2017 scoring standards are different for MIPS APMs than they are for MIPS clinicians. And this table provides nice details on the specifics for the MIPS APMs. The quality payment program measures are included in the 33 Medicare Shared Savings Program measures that the ACO submits on behalf of the ACO participant tax ID numbers and their MIPS eligible clinicians via the CMS web interface. You will need to submit data. You will use data for a full calendar year for reporting, and this is also different than you saw on the previous slide. And the ACO will submit the measures on your behalf. Now, the data that's submitted on the first is submitted on the first 248 consecutively ranked and assigned Medicare beneficiaries. So the ACO submits this information just once for both the Medicare Shared Savings Program and MIPS. And how are they scored? The MIPS benchmarks will be used to assign one score at the APM entity group level. In other words, all MIPS-eligible clinicians on the Certified ACO Participation List will receive the same score unless they're excluded from MIPS. And the performance of all clinicians in the ACO will contribute to the score, even if they're not subject to MIPS payment adjustment. So that's, Sandy will talk about that later. And again, it's weighted at 50% instead of 60% for the others. Another great table to keep here to help you keep it straight if you need to. Now, let's talk about benchmarks and the importance of deciding which measures to select. Really, selecting your measures is a strategy. A lot different than previously used maybe with the Meaningful Use program where you just had to submit some data that was greater than 0% if you even had that. So it really is a lot different, and those that will score higher in this category will take the time to go through this process we're going to talk about. So benchmarks, what are they? Each quality measure is assessed against the benchmark to determine the number of points the measure earns. And you will receive either anywhere from 3 points minimum to 10 points for each measure, not including those bonus points we talked about. So the benchmarks are specific to the type of submission mechanism. So if you use an EHR, the benchmarks are different than if you submit via claims. And we'll show you some examples of that. That's also an important thing to note. So based on the actual performance data submitted to PQRS in 2015, so this information is coming from there except for CAPS. And the CAPS benchmarks are based on two sets of surveys, the 2015 CAPS for PQRS and the CAPS for ACO. Now, how does the benchmark tie with the amount of points that you will get for each measure? This table shows us how the benchmark decile determines the number of points you receive for that specific measure. And please note here that if you score any percentage below the third decile, you will still score 3 points for that measure in this 2017 transition year. So let's say we have a percentage and it shows that we're in the 6th decile. We know that we're going to score anywhere between 6 and 6.9 points. We're going to take a look at the benchmark for breast cancer screening in a minute. And in that example, you're going to see that each benchmark contains a measure name and ID, the submission type, which way you're submitting that data, and the measure type, like for instance, is it outcome or process, and whether or not that benchmark can be calculated for that measure submission mechanism. The range of performance rates for each decile will be broken out, so we'll be able to determine which decile we're in very easily, and whether the benchmark is topped out. So you probably have heard about topped out measures, but if you aren't aware, it's a measure where there's not a lot of variability. Everyone's doing quite well, and it may have difficulty scoring this in future years. So they're going to be determining that, and it'll indicate that on the benchmark spreadsheet we'll look at here in just a second. So how do you find your benchmarks? Where do I go to find these? If you go out to the CMS website for the Quality Payment Program, and that website URL is right here, qpp.cms.gov, you'll find an awesome website with a lot of interactive tools and webinars and just a wealth of information. They're continually adding. They just added some more tools just this week. So I can't stress enough how important it is to go out to that website for more than just finding your benchmarks. But for the purposes today, you would go to that website, and then it's going to take you to a screen. And please forgive me for the small print, but I want to give you just a little glimpse of what you're going to see. So on the left-hand side, you're going to see the screen at the top, the bar at the top will have an option for education and tools. You select that, and then you scroll towards the bottom of the screen where you will see under the category for registries, qualified clinical data registries, and EHR vendors, the third one down for right now anyway, you will see there's a file titled 2017 Quality Benchmark, which you will select, and it'll take you to a zip file. You will open up the zip file, and then you will select the Excel file titled MIPS Benchmark Results. When you open it up, you'll see something like this. Now, I know that this is extremely small, but I just want to give you an idea of what this looks like, and we're going to drill down to the breast cancer screening example. It's a little bit bigger print. I know it's still small, but I just want to show you this as an example so that you're not overwhelmed by that big spreadsheet that you will see. So, as I mentioned previously, you'll see that the quality measure name is there, breast cancer screening, and its ID, number 112. Then you'll see the submission method, and you'll see claim, EHR, or registry, or qualified clinical data registry. So that's very important to pay attention to because depending on your submission method, those percentages for the deciles will be different, thus your points will be different. Now the next type, you can see this is a process measure, and benchmark, there's a Y. That means, yes, there are benchmarks for this measure. And then it starts with decile 3. And remember that I said in the 2017 year that even if your percentages fall below the third decile, you will automatically receive, be in the third decile. You'll automatically receive the 3 points. So just so you know that, that's why decile 1 and decile 2 are not there yet. Now, let's say that my clinician scored 51% on this measure, a nice round 51% on the breast cancer screening measure. You will see that this shows if you follow the claims around straight across there to 51%, you'll see that this clinician is in the fourth decile if they submit their measures via claims. But if they submit their measures via the EHR, it bumps all the way up to the seventh decile. And finally, if they are submitting via the registry, then they fall in the sixth decile. And Sandy will discuss this a lot more later, but I just want to stress the importance of reviewing your percentages now from your reports, pulling those reports to get a baseline of where your providers are, and then comparing the measures that you're considering, maybe not just 6, maybe you want to look at those that have the highest percentages because or others that may not seem like you're doing as well, but when you look at the benchmarks, that you might receive more points for percentages where you aren't performing as well compared to those where maybe everybody's getting used to this measure and they are performing well, so you would even fall in a lower decile. So this is where when we say strategy, it truly is a strategy. Now, the benchmarks for quality are determined 2 years prior to the performance year, and new measures are benchmarked during the performance year. If you use the CMS web interface, they are using the Medicare Shared Savings Program benchmarks. And finally, cost for this year is determined during the performance year. The benchmarks, again, I wanted to stress, are specific to the submission method, and for new measures, you will receive, it has a 3-point floor. The benchmarks are risk adjusted to the hierarchical condition code, and you must have 20 or more eligible instances or cases to contribute. So your denominator must be at least 20. If it's not, then it will not be used. And a 0% performance is not included in your score. Now I'm going to turn it over to Sandy, and she's going to show us some great examples of the quality scoring methodology.
Well, thank you, Michelle. I actually get the pleasure of sitting next to Michelle now, and she's, as you can tell, an expert on the QPP program, so I really appreciate that. Just one of the things I wanted to say, as you're nervous about all of this with QPP, if you're already participating in PQRS and you've been doing this for the last 2 years, you're already familiar with submitting quality measures, So by just reporting just one quality measure, you can receive 3 points this year and avoid the payment adjustment. Now, the scoring methodology for the QPP program, quality category in the QPP program, is different than what it was for PQRS, because as you know, PQRS, we weren't really based on, your payment adjustment wasn't based on performance. But now with it being based on performance, the scoring methodology has changed a little bit. So my goal is really to explain that scoring methodology well enough that you'll be prepared to do very well on this category, and you won't even think about just submitting one quality measure. You're going to go ahead and go for it all. Okay, so let's start with talking about, excuse me, let's start with talking about individual measure scoring first. Michelle talked to you about reporting options as an individual or a group where you would need to submit 6 measures. Then there's also your opportunity that you could, if you have groups, if you have more than 25 eligible clinicians, you could, or providers actually, you could use the CMS web interface if you would register for that by June 30th. And if you are doing a CMS web interface, you're going to be submitting 15 measures. And those 15 measures will be, are the same measures for everybody submitting to that web interface, and those are the 2017 measures. And there is a list out there that you can Google or send an email to Michelle or myself, and we'll get that list right to you. Now, if you're participating in an ACO, track 1, 2, or 3, a Medicare Shared Savings ACO, you'll be submitting, your ACO will be submitting on your behalf, as Michelle told you, and those will be through the CMS web interface. That's one of the requirements, and it will be for a full year. Anybody that's submitting through the CMS web interface, it is for a full year. Now, when your ACO submits quality measures, which are part of the participation requirements being an ACO, there's like 30 plus measures they're submitting. 15 of those measures are actually from the CMS web interface measures list. And so when they calculate your score for QPP, they'll just be looking at those measures for the ACO. So that way you're all being measured on the same, everybody that's participating in the CMS web interface is being measured the same. All right, now let's go back to, for each individual measure, it's going to be scored as a decile on a decile score, scale of 1 to 10. And as Michelle said, if you're missing a measure, then you get 0 for that measure. Now, for all reporting options except the CMS web interface, you have the option to submit more than 6 measures, and CMS will figure out which one are your highest scoring measures, and you will get, your score will be based on those 6. Now, you're going to submit, what you'll do is you'll submit a numerator and a denominator for that measure, either you, or if you choose to have it through an EHR, your EHR direct or your quality registry, whomever does your submission, whichever method you're going to use, you'll submit the numerator and denominator, which is then converted into a percentage between 0 and 100%. And then that gets converted to a decile scale, which is points 1 to 10, depending on where it falls in the benchmark. So that's kind of what that little diagram there at the bottom is, converting a performance rate to a standard score. So you're just going to submit a numerator and denominator, and CMS is going to do the rest of the work. Let's talk about the maximum number of points before I give you some hypothetical examples. The quality category has 2 sets of measures. There's the measures that are submitted by the providers, or submitted on your behalf of the providers, and then there's the CMS calculated measures. So in 2017, CMS will use just one measure to contribute to the quality score, or their calculated measures, and that's the all-cause hospital readmission measure, and that's for groups of 15 or greater, or have over 200 attributed hospitalizations to them. So the only time that all-cause hospital readmission, and it's called the ACR measure, is being calculated are for those particular circumstances, groups of 15 or greater and over 200 attributed hospitalizations. Otherwise, CMS for the year 2017 will not be using the readmission measures. Okay, so you can see on this slide the difference in the scores. So let's start with the left, a box on the left. If you are reporting through the CMS web interface, then you have an opportunity to earn 120 points for groups with a complete reporting and the readmission measures. If you are submitting through, or if your group is reporting but no readmission measure is being used for you, you have an opportunity to earn 110 points. Now, if you're using other submission mechanisms, your total points could be 70 points for the 6 measures that you submit, or the 6 that are going to be calculated, plus the readmission measure if you qualify for that. If you don't qualify for the readmission measure, then you're only going to be scored on the 6 measures, the top 6 measures that were submitted, for a total of 60 points. I know that's confusing. Hopefully that slide, you'll look that through and it'll make a little bit more sense to you. I wanted to just tell you too, in the future, if you that are familiar with your QRUR reports and looking at the cost and quality on those, in the past, CMS calculated not just with the calculated measures the admission measure, but they also did the acute conditions composite and the chronic condition composite CMS calculated measures. This year they're not going to be using those for 2017. So when you get your feedback reports, those won't be included. However, they will be scored in the future. And when they talk about acute conditions, it's made up of scores related to hospital admissions for bacterial pneumonia, urinary tract infection, and dehydration. And the chronic condition score is made up of diabetes, chronic obstructive pulmonary disease, or asthma and heart failure. So that's coming up in the future when they look at CMS calculated measures. All right. Let's look at converting a performance rate to a standard score. We're going to break down this. This is, when you think about this is really not a mathematical determination, but it's more a ranking determination. This example that I'm showing you here on the slide is a quality measure that we're going to just say that this was a quality measure that you did through your qualified registry. Because remember, your benchmarks, as Michelle said, are different depending on what reporting mechanism you use. So your quality measure came in with between 36 and 40, or in the 5th decile, that you can see right here. Okay, well, when you look at your percentage actually was 38%. So you fell between 37.96 and the 38.44%. So you're going to receive, for that particular quality measure, you're going to receive 5.4. Now let's just go back to Michelle's example. I think she said she used the breast cancer screening and 51% is what your score was. Now this obviously is not the benchmark for breast cancer, but let's just pretend it is. So if you fell into 51%, you're going to get in the sixth decile for if this was that benchmark. So you would get between 6.0 and 6.9. Now I can't give you exactly where you're going to be because this particular example doesn't go up to 51%. But it'll be between 6.0 and 6.9 you would have gotten if you would have been using this benchmark for your breast cancer. So again, this is a hypothetical scoring example, and this was actually provided by CMS to us. And what this in the red box, is showing you is the possible score for this particular example. So again, this is going to be someone who is an individual who has sent this through a qualified registry who did not qualify for the all-cause hospital readmission claims. And you can see that on the bottom. It says readmit administrative claims. That means it's calculated from CMS, and its eligibility is NA, so it's not scored, so you just get 0. But the total possible points, if you add those up, you've got 610, so you've got 60 total possible points, or maximum points. Now, if the administration claim would have been scored because you had 20 eligible or 200 eligible cases, then that would have been 10 points for that, and it would have been a total of 70 points. All right, so going on to the next slide. So this is the exact same hypothetical scoring example, but now we're looking at the performance points. So for column 1, the measure, and they've named the measures A, B, C, D, E, F. For the 6 measures, that could be diabetes, hemoglobin A1C, fall prevention, whatever those measures are. You will, when you see your feedback report, it'll tell you the measure. It'll tell you the measure type. In this type, the measure A is an outcome measure. And eligibility instances, there were 20 cases, so you have to have 20 or more cases before it will be scored. And you fill in whatever your numerator and denominator were that were submitted on your behalf. You came in and received a score, a ranking in your decile of 4.1 of a total possible of 10. Okay? So you can look at each one of these measures here, and for measure B, you got a 9.3. You did really well. For measure C, you got a 10. You did super. D, you got a 10. And E, you got 8.5. And then F was missing. So you missed the 6th measure. It's still going to count under your total possible points because you should have submitted 6 measures, and they would have calculated 6 measures, but you're going to get 0 points for that. So when you add those scores up, you get 41.9 actual points for your performance. The same exact scoring example, but now we're going to look over here on the columns with the priority bonus and the certified EHR technology bonus. So for measure A, you don't get any priority bonus points for that because that's the one required outcome measure. But measure B, patient experience, you're going to get 2 priority bonus points for submitting a patient experience measure. And then measure C, you're not going to get any priority bonus points for that. But measure D is your second outcome measure. And because you submitted a second outcome measure, you're going to get 2 priority bonus points for that. Measure E is a high priority patient safety. So high priority measures are going to give you 1 priority bonus point. So if you total up your priority bonus points, you get 5 priority bonus points. Now remember, the priority bonus points are capped at 10% of the denominator, and the highest you can go is 7. So even if you are on the CMS web interface, even if you are on the CMS web interface, you can't get 10% of 120 points or 110 points. It's capped at 7. So you can't get 12 priority bonus points. Okay? So it's capped at 7. So right here, you're going to get 5 priority bonus points. And then we look at the CEHRT bonus points, it's the same thing. For these 3 that you received, the certified EHR technology bonus points, it's because it was submitted through end-to-end submission. And Michelle explained what electronic end-to-end submission was, where you submit it, it's pulled raw data, it's pulled directly from your EHR, goes to your submitting vendor, who then submits it, and there's no abstraction done through it. And that's something you will want to talk with whoever's going to do the submission of your measures for you to see if you have the opportunity to earn bonus points because of that, along with working with your vendor to see. All right, so the next slide, we've got the same example here. So we look at this, we had 41.9 actual points for our performance points. We got 8 bonus points between the priority bonus and the CEHRT bonus for a total of 49.9 points out of a possible 60. You divide that by 60 and you come up with 83.2% is what your score is for this particular hypothetical scoring example. Now remember, the maximum quality performance score is at 60% for quality. So quality is at 60% for an individual reporting. Now if you were an ACO, participated in the the Medicare Toward Savings Plan 1, 2, or 3 and using the MIPS APM, then your quality scoring would be 50%. But this example, I'm using 60% as an individual. So they'll take 60% of your 83.2%, and you end up with 49.9 points in the composite score for quality. Now, that score will get added to your cost score, your cost is 0, but your improvement activity score and your ACI score, and to come up with your final score to determine what the payment adjustment, where you fall on the threshold for your payment adjustment. So hopefully this makes sense to you, and the examples help a little bit. So Michelle and I, we don't want you to just survive and thrive in the quality category. We're high performers. We expect a lot out of you. I think you all expect a lot out of yourself. So we wanted to come up with, say, some keys to success. So for the CMS calculated measures, similar to the scoring for the cost category in the value modifier program, you need to really, by focusing on taking good care of the patients with your chronic conditions and treating your acute conditions early to avoid hospitalizations, that's going to be your best approach to influencing the score for this particular category. And when you get to the when the cost category is measured and calculated, that will help with that also. Now, for the measures that you submit, Michelle talked to you a lot about how to select the measures and looking at the benchmarks. Choosing the right measures to report on, that's become extremely important now that performance counts. And we really recommend that you submit more than 6 if you can. I know some of the specialties, their scope of work don't really, more than 6 may not fall for that, and that's okay. But if you can, at least have some back in the hopper to be watching and monitoring, because continuously monitoring your performance and continuously looking at your performance and thinking, how can we improve this performance? What processes, what simple interventions and processes we can put into place to improve some of these performances, that's going to be huge in improving your score. Now, for both, another helpful tip, for both the CMS calculated measures and the submitted measures, take a look at your QRUR reports as far back as you're able. Do you find that the scores are to be at or below benchmarks? Now, there's really no guarantee that your past performance is the best, but that your past performance is what your performance now is going to be. But it really is the best indicator, unless you kind of radically change how you take care of your patients. Now, if your score on the QRUR is below benchmarks in any sections, you want to look closely at those areas and practice that influence, and the practices that are influencing that score, and that's when you really want to look at it, putting in some continuous metric improvement programs. We also recommend that you provide complete follow-ups with your patients that are post-hospitalization, and I've seen this in some of the clinics, the larger clinics that we've worked with over the last few years with QRUR reports. They've implemented some post-hospitalization programs and phone calls and getting the patient in within so many days, and that really has helped to reduce their readmission rates, which then again will help with both the quality category and the cost category. All right, we've given you a lot of information, and CMS really wants to provide everyone with free assistance that's easy to find. So I know Michelle has had some webinars on this in the past, is where can eligible clinicians go for help. This slide shows you here in Iowa we have self-serve. There's a self-serve via the CMS QPP website, and that's for anybody and everybody. And then there's also these specialized programs. There's the Transforming Clinical Practice Initiative. In Iowa, that's the TCPI. PTN through the Iowa Healthcare Collaborative, and you have every state has a quality improvement organization and a STIR that is available to them, and then the best organization for you to reach out to really is going to be depend on your practice size, your practice goals and strategies, and whether or not you're participating in an ACO. So this slide right here just talks about who we are, who those are. So let's start here. I'm going to look at how much time I have here, because we want to leave time for questions. So let's just start here at the bottom real quickly. All eligible clinicians are supported by the QPP website. I recommend, if you haven't been out there, to go out and look at that. It's www.qpp.cms.gov. Also, if you scroll down to the bottom of where it's educational tools and resources, you can submit to be on their distribution list for any updates, and I recommend that you do that too. If you are in a small, rural, underserved practice, then you may, and with 15 or fewer clinicians, eligible clinicians, you'll want to reach out to your SERV. And if you are in a larger practice with 16 or greater, you are in a larger health system, or you are in an ACO, then the QIO or the Twin QIO, which is me here in Iowa, then we are the best specialized program for you to provide you with some assistance. Now, if you're a primary care or specialist physician and you're really wanting more support, more one-on-one support, and more of how to transition to an APN, which is the overall goal of the whole program, then you will want to reach out to your PTN. This is the resource slide that Michelle referenced earlier, and I think that gives us just enough time for a few questions. Michelle's going to open the lines, and
the leader has unmuted your
what
line.
questions you might have from us, and also let us know what else we could be educating you on. Next month, May 25th, we'll be doing the same type of presentation for the ACI category, and the following month we'll be doing a presentation on cost and improvement activities, just breaking down the requirements and then the scoring methodology for each. So lines are open. We'd love to hear from you.
Hi, my name's April. My physicians are part of a specialty clinic, but we're also part of an ACO. Does this mean that my data will come from the ACO, or will it come from me directly from claims or from my EMR, or either or both?
If you are part of an ACO, and you'll want to definitely visit with your ACO administration, but that's one of the requirements of the ACO is that they're submitting the quality measures, and there's for this year 33, I think it's 33 or 30 plus quality measures, which will include the QPP measures. So you will not be responsible for submitting those. Your ACO will be responsible for submitting your quality measures. However, you are responsible for making your measures look better, and definitely I would want to look at what your outcomes are to see, how can we improve upon those measures to bring up the whole score for everybody in the ACO. Does that help you, April?
Yes, thank you.
You're welcome. Thank you for the question.
I have a question.
Hi, yes, go right ahead.
Yeah, so this is Paul, and if I'm a solo practitioner and I want to participate in the Pick Your Pace program, and my objective is really not to get the negative 4% payment adjustment. If I were to report a single quality measure that includes a denominator of 20 patients, and I score in the lowest decile, do I still get my 3 points that gets me above the threshold to avoid the negative payment adjustment?
Great question, Paul. And yes, you will receive 3 points. For 2017, you will receive 3 points for just submitting a measure that qualifies. Now, one thing, if I were a solo practitioner and I wanted to just avoid the payment adjustment, I would consider going to the improvement activities category and looking at those activities and seeing if I already have one of those activities in place. because you can do that directly. You can attest to that directly through attestation. Portal, and you're not having to involve a QCDR file, or you're not having to involve a qualified registry, which costs money to report through a qualified registry. So if your only objective is to just submit enough to avoid the payment adjustment, I think the simplest way for you to do that is to do that through an improvement activity. And one of the ones that you might even look at is the access to care. Are you providing 24/7 access to care in urgent emergent situations where your patients know how to get a hold of you and where the after clinic hours are, et cetera? Do you have those posted? Are they on your brochures? Are they included in your newsletters? That type of thing. So I'll give you a little more information than you asked for, but.
And where you can find those improvement activities, just go to that qpp.cms.gov. and go to the Explore categories and then click on Improvement Activities, and you'll see those listed there. Thanks for your question, Paul. We have somebody else out there that has a question?
I have a question.
Sure.
So my question is, we're a hospital that's part of an ACO, and we're going to do a as a
When
group.
you or loved one needs care following an accident, illness, or surgery and wants to recover at home,
Somebody can
regional medical home.
if you just want to, thank you.
Okay, sorry. So
Go ahead and start over for us.
my question is, we're part of an ACO, and we're going to be reporting for all of our physicians. Then does that include all of our, like, the CRNAs that do their own billing? Like, we have a group of anesthesiologists that come and perform procedures here, and we bill for the facility fees, but they do their own professional fees. Do we have to report for them?
Are you referring to the quality category?
Well, all of it, actually. But
Okay. Because if for the quality category, they would have to be on your ACO participant list to be included in the quality measures that are being submitted that are going for your quality score. Okay. So let's go back to your scenario again. I want to make sure I understand it. So you're an ACO, you're a clinic, and you are in an ACO, and you have clinicians that just come in as satellite clinicians. Is that correct?
yes, we do have that situation too, where we have like satellite clinics. But I was specifically asking about our CRNAs, so the nurse anesthetists that come in and perform like epidurals. We bill for their facility costs, but to the patients, but they do their own professional billing.
Okay. So if you're not billing Medicare Part B professional services for them, then you will not need to do their billing. They will not be included in your scoring. However, if they're billing Medicare Part B themselves through their other entity, through that another TIN connected to their MPI, then they would be affected by a payment adjustment, and they would definitely want to be submitting data on their behalf.
Okay, that answers my question. And is that the same then for our specialty providers that come to our facility? If we do not bill for them professionally, then we are not responsible for reporting for them, correct?
If you are not billing Medicare Part B services for them, okay, because it's only refers to the Medicare Part B services for the quality payment program.
Another quick question. When you talked about the ACO, you said, what did you say? You said measures that are submitted are only for the doctors in the ACO.
Each ACO is required at the beginning of the year to submit what they're calling in the QPP program, they're calling it a participation list. But under the ACO, on your behalf and your requirements of the Medicare, and I'm referring to Medicare Shared Savings Plans ACOs. I'm not referring to any of those like insurance well-marked ACOs. We're just talking today about the Medicare Shared Savings Plans, Track 1, 2, and 3 ACOs. Okay, so they're required to submit a provider supplier list at the beginning of the year, and that's to include all providers by their TIN and their MPI, and then they need to keep that up to date every month. And then CMS will take a snapshot look at those providers and their MPI numbers that are on that 3 times a year, towards the end of March, the end of June, and the end of August. And any participant that's on that list will be considered a participant for that ACO entity 10. Okay, so that's the list that I'm referring to. And if they're on that list, then they will be considered that the quality data that's submitted by the ACO goes towards those particular participants. Now, if you get, like, maybe you add a physician, say, like, in September, so they weren't on that list, then you'll need to report individually for that provider, that physician, that eligible clinician, individually for him for the 2017 reporting period. But then when 2018 falls around, hopefully the ACO will add that provider to their participant list for 2018, and they'll be included in that. So that's why it's very important to, number one, keep your PCOs up to date, and number two, make sure that whoever your ACO administrator is as your organization, you need to keep them up to date when you add and delete providers in your practices.
What if we gave our list for our ACO and we have the providers on there who we aren't billing professional Medicare Part D for? If they're on there by accident?
You know, I would just give them a call, whoever is administrating that list, and give them a call and just let them know that. Some of the ACO requirements are, I'm only referring to the QPP program, and some of the ACO requirements are different, and it includes eligible clinicians that are not necessarily eligible for the QPP program. So they probably have 2 lists, but I would just reach out to them and just let them know, you know, find out what they want, how they want you to work with that.
I hate to say we're over time, but I have the slide up with Sandy's information as well as mine, and if you have any questions or would like to begin working with us, we'd love to hear from you, so please contact us, and we thank you again for your time today. The next webinar will be Thursday, May 25th from 12 to 1 o'clock, and that is on the Advancing Care Information category. Thanks so much and have a great day.